Hello, I'm Simon Patterson-Brown, Consultant General and Upper Gastrointestinal Surgeon in the Royal Infirmary of Edinburgh.
Hello, I'm Craig McElhenney. I'm a Consultant Urologist in Forth Valley in Largo in Scotland.
This is part 2 of a series of lectures we're giving on non-technical skills for surgeons, an introductory workshop. In this second lecture, we're going to focus on the non-technical skills that we discussed in the first lecture and introduced and showed you how we got to them, the NOTSS taxonomy. There are 2 sections to the NOTSS taxonomy, the cognitive skills and the social skills. And we're going to start first with the cognitive skills. And these are situation awareness and decision making. And these are the skills where you need to think about what you're doing. And we're going to start with situation awareness, what we would define as skills for diagnosing the situation and then reaching a judgment in order to choose an appropriate action. Without good situation awareness, we can't make decisions. And there are 3 elements to decision making: gathering information, understanding the information, and then projecting what might happen in the future and what we can do about it. And the idea of situation awareness, which has been explained by the psychologist Mika Ensley many years ago, is about our interpretation of what is happening in our environment. As I mentioned, it is a precursor to decision making, but it's a very important part of our non-technical skills. In other words, what is happening around us. The part 1 is perception. The information that we get in, we hear, we may feel in the operating theatre, we may see when we're doing an operation. That is our perception. We then need to understand what do all those factors mean to us. And for part of that, we will need some experience, and the novice will find that a little bit more difficult. And once we've understood what is happening, we then need to project as what is going to happen in the future, and therefore what can we do to alter what might happen in the future. So perception, what is happening? Large amounts of data, dynamic. The data changes all the time, particularly in the operating theatre. What's the relevant data? What data do I not need to take account for? And what's the priority of the data? What do I need to take account of first and perhaps take action for that? The second level of situation awareness, comprehension. So what? In other words, what does that data mean? And we use that data to update what we call our mental model, and we'll again come to that later on, so that we are aware of what is happening and what does that mean. And with all that information, we then have to anticipate and project what will happen thereafter. We use that data to update our mental model. It allows us to go on to analytical decision making, and to an extent, the more experienced you are, the more you will understand level 2 and be able to project what happens in level 3. There are barriers to our situation awareness. As Craig talked about earlier on, things that can go wrong in theatre. Distractions can interfere with our cognitive function and the information we're getting in. Someone comes into theatre, interrupts, music's too loud, something else happens, and we're distracted from getting the information we wanted. We can get fixated, we can have tunnel vision, we have inattentional blindness, we can have inattentional deafness, where we're so focused on a task that we don't pick up other information that may be around us in the operating theatre, and that might be important information. We can sometimes think in isolation. We think we understand what's happening, but other people may take a completely different view of the same information that's available. And we have to recognize that stress and fatigue, which affects us all, influences our cognitive ability and therefore our situation awareness.
Next, we're going to talk about decision making. Decision making is the second of the cognitive categories in the NOTSS taxonomy. And again, as the name suggests, it's one of the thinking skills that we use in the operating theatre. Again, like all the other categories in the NOTSS taxonomy, it's divided into three elements. Those of considering the options, selecting and then communicating an option, and then implementing and then reviewing any decision that you make. We don't often think about how we actually make decisions in the operating theatre. But this model that you can see is the so-called standard analytical model of decision making, which is well known to psychologists. We will make a situational assessment, which involves having good situation awareness that Simon has just described. Basically, that tells us what is the problem. And obviously, if your situation awareness is wrong, i.e. your assessment of the problem is wrong, any subsequent decision made on that information is likely to be wrong. And that's why situation awareness is key to good decision making. After the situation assessment, you decide what to do. You weigh up the options and select a course of action. After that, you implement that course of action. And in a continuous loop, you should then review your implementation of that action to see if it has had the desired effect. Have you improved the situation? Have you made the situation worse? And along with situation awareness, this is a constant running loop with you updating your mental model constantly and allowing that to make good decisions in the operating theatre. However, we are aware that this analytical model of decision making is not how we make decisions all the time. When you drive your car to work, you're not consciously making decisions every second, at every turn, and every roundabout. Most of that decision making is made at a subconscious level. And the same is true in the operating theatre when you're an experienced surgeon. You don't consciously make decisions all the time. Some of you may have read this work by Daniel Kahneman. He's a psychologist who won a Nobel Prize for his work into thinking and decision making. And he's divided thinking and decision making into essentially two types. One is what he calls slow thinking, hence the title, Thinking Fast and Slow. And this is where you are going through this process very consciously of measuring up options, selecting an option, and implementing that action. But most of the time, we use what he calls fast thinking. This was an idea originally put out by Gary Klein, a psychologist, who looked into decision making in high-risk situations made by firefighters in the USA. When he asked them how they made decisions in high-pressured situations, he was very surprised to hear when they said, "We don't make decisions." But actually, when he drilled down into this, they were making decisions, but again, they were making them very fast and at a subconscious level. Essentially, they were pattern matching and coming up with instant solutions. And we now know that we spend approximately 80% of our time in the operating theatre in this fast pattern matching mode. However, we also know that this can be where adverse events happen. This fast method of decision making is prone to bias and heuristics, which are shortcuts that our brain takes. And while most of these are useful, occasionally they can be prone to error. These two systems of thinking and decision making also use two different parts of our brain. Our working memory, we know, is actually fairly small. Our brain can only hold somewhere between 5 and 7 distinct chunks of information at any one time. And if we're using this very effortful, slow, analytical decision-making process, our working memory can become fairly quickly overloaded and make us unable to make decisions. If we're using our fast decision-making process, we use our long-term memory. And that doesn't use this effortful working memory, which means that if we are using fast decision-making subconsciously, we have an ability to continue to use our working memory to think through problems at the same time. And the problem is we know that our working memory is very susceptible to a whole host of things such as stress, overwork, a rapidly changing environment, such as you might get in the operating theatre. If you're in an unfamiliar environment, such as operating theatre you don't normally work in. If you're inexperienced, if someone is rude to you, all these things adversely affect our working memory and our ability to make decisions. These things physically shrink our green box, which is our working memory, and make it more difficult for us to make good decisions. An important aspect of non-technical skills is recognizing this disparity between the two forms of decision-making and deciding which method of decision-making is optimal for which situation. In the NOTSS Masterclass, we discuss this much more fully, and we also discuss how you can improve and optimize your decision-making in the operating theatre. Using the fast, subconscious decision-making process is not always good, and we can teach you cues when you should slow down into the more effortful, analytical decision-making mode. We can also teach you how things like protocols can be helpful and how you can help offload stress and share decision-making to preserve your working memory in the operating theatre to ensure that you continue to make good decisions.
So we'll move on now to the social categories of the NOTSS taxonomy. These are the skills that allow us to work within the team, within other people, with other people. And they are communication and teamwork and leadership. Communication and teamwork are skills for working in a team to ensure that the team has an acceptable, shared mental model of what's happening and that the task can be completed successfully, in our case, the surgical operation. They involve three elements: exchanging information, establishing a shared understanding between members of the team, and coordinating team activities. And we have to remember that the operating theatre is a busy place. There's a lot of people all there, all with different jobs, and their jobs, of course, may be different any day of the week. We're all focused around the patient and with an aim of getting the operation done successfully. But we also have the equipment that sometimes impedes how we react with the patient. And increasingly, operating theatres are extremely complex with a lot of complex equipment. And all this has to be brought together if the team is going to work closely together for the benefit of the patient. We know from a large amount of literature that's come out that it's the communication failures in the operating theatre that lead to patient injury. Information may not be transmitted, or it may be inaccurately received. We know that less information shared is associated with a greater risk of a complication. And we know from medical litigation studies that communication failures are at least a quarter of all those cases. And in fact, many of us would think that they are much higher than that. So we're going to come back to the mental model that both Craig and I have talked about earlier on. Each person in the operating theatre has a different job, but of course, a large part of that job is interrelated in getting the operation done for the patient. And this Venn diagram shows the crossover of knowledge between the different members of the operating team. Here, the surgeon, the anaesthetist, and the scrub nurse. And the white area in the middle is our shared mental model. And a good team will have a much larger white area than a team that perhaps isn't functioning so well. So that is what a good team needs to expand. Think to yourselves for a short time, how do you recognize when other people do not share your mental model? What is it in the operating theatre that makes you think that they are not reading from the same hymn sheet? People say silly things. But they don't mean to say silly things. They're just thinking something completely different than you are. So stupidity, if someone asks a stupid question, you need to think carefully, why are they thinking that question? What is it that I'm missing that they're picking up? Because remember, their mental model may be correct and yours may be wrong. Odd questions, strange answers, inappropriate actions. All these would suggest that the mental model in theatre is not shared by different members of the team. And of course, we've got barriers in the operating theatre to communication. We've got external barriers, we've mentioned them before. Noise, various distractions in theatre. Mumbling, quiet voice. Electrical interference from the instruments. Separation in time and space, when you're phoning someone perhaps from the operating theatre and in a different place. We know that excessive and negative communication, what was shown in this book that we've shown here, the human factors of fratricide, in other words, shooting down your own team, sometimes too much communication and too negative communication can have a worse effect on the shared mental model. Lack of visual cues, because we've got masks on, can't see what's happening. Body language, eye contact, gestures, and so on. And we've got internal barriers to communication. Language differences. Increasingly, we're working in a society with many different cultures and languages in the operating room. Someone might be deaf and you don't know that they're deaf. Different cultures. Motivation may be different from other members of the team. The expectations of how they behave in theatre and how they get on with others may influence how they respond and work in the team. Past experience. If someone's been given a row for asking a stupid question, they're not going to ask that question again, whereas it might be a very important question. Status and hierarchy. Is everybody in the operating theatre happy to stand up and ask a question, to say that they're uncomfortable, that something's going wrong and that we should stop, reassess and think again? Is everybody in your theatre happy to put their hand up and say stop? And of course, everybody's emotions and moods change from one day to the next. So how do we improve our communication? We don't make assumptions. We're clear in what we say and we're precise. We pick our moment, because if someone's in the middle of doing a difficult procedure, they may not be able to hear you because they're focused and fixated on their task. We need a little bit better structured communication, such as using the ICE-bar or S-bar communication format. We need to verify when information has been received, and we need to clarify if there's any ambiguity. So let's go on to teamwork. We know that high-performing teams have strong team leadership. They hold a shared mental model between all members of the team. They have clear roles and responsibilities. They cooperate together and they display backup behaviours whereby they share tasks. They look out for others and they support others in the operating theatre to help get the task done. And they evaluate their own team performance on a regular basis.
The second of the social categories in the NOTSS taxonomy is that of leadership. And this is leadership in the operating theatre rather than at a management type level. Once again, as all the categories, as a NOTSS definition, which is leading the team, providing direction, demonstrating high standards of clinical practice and care, and being considerate of the needs of your individual team members. Once again, we have three elements, which are setting standards, supporting others, and coping with pressure. I'd like you to just think for a minute, what does make a good leader? This is a question we perhaps don't ask ourselves enough as operating surgeons. What actually makes a good, effective, safe leader in the operating theatre? There are a whole host of leadership models out there. Books and books have been written on this subject. If you actually look into the literature on leadership in surgery, it's fairly sparse. Probably the most important concept we'd like to grasp as leaders in the operating theatre is this difference between so-called transactional leadership and transformational leadership. Transactional leadership is a much more management style, whereas what we should be aiming for in the operating theatre is transformational leadership, where we are inspiring people to do what we want to do. And there's now emerging evidence that transformational leadership in the operating theatre has a positive effect on the team working within the operating theatre and also a positive effect on your patient outcomes. So leadership, again, has a definite impact on the outcomes for your patients. As I said, the leadership literature in surgery is fairly sparse, but if we look at the leadership literature from other high-risk industries, we know that good leadership is associated with decreased errors, reduced costs, improvements in safety, and increased compliance with things like standard operating procedures, which for us would be the surgical checklist. As I said, however, we don't have that much evidence in surgery. What evidence there is, most of it has been produced by Sarah Hendrickson Parker, a psychologist who used to work for the Mayo Clinic, who now works for MedStar Health. And she performed lots of observations of leadership behaviours by consultant surgeons in the operating theatre. The first thing she discovered was that we probably don't display as much leadership behaviour as we probably should as the leader of that surgical team. But what she did was she identified 7 leadership behaviours that surgical consultants should be carrying out, and she called this the surgeon's leadership inventory. And the important thing to realise about these behaviours is 4 out of the 7 are focused on the surgical task. And these are the ones we are quite good at in the operating theatre. However, to be a truly effective leader, to demonstrate that transformational leadership style we've discussed, you really also have to focus on these 3 other behaviours which are very focused on improving the work and performance of your surgical team. And we know from the evidence that we as consultant surgeons are not as good at displaying these leadership behaviours. But these are vital if we are to have high-performing teams within the operating theatre. To illustrate non-technical skills in action, we are now going to show you a video. This video we've been given permission to show this video by Augusto Azuro Blanco from Aberdeen Royal Infirmary. It's based in the Ophthalmology theatre, and we'd like you to take a look at the non-technical skills involved in this scenario. You're rating the consultant ophthalmologist. As you watch the video, I'd like you to assess his behaviours and try and coach them in terms of the NOTSS taxonomy. So try and describe them in terms of situation awareness, decision making, communication and team working, and leadership. As you're watching the video, think about how you would debrief this surgeon at the end of the procedure to how he could improve his non-technical skills.
Hi, I know I'm late. I'm so sorry. I had a meeting.
We don't want too late today.
I know. You can sit for the first station. I'll just change and come back.
Okay, we'll do.
Can we do a surgical pause, please?
There's no time. I have to be off about 12 o'clock.
What eye is it we're doing? It's the right on the list. It says right on the list.
Yeah.
It's left eye in the consent form.
Okay.
Which
was it?
Well, that's what I read.
Which eye we're doing for you, Mr. Smith?
What?
Which eye we're doing for you?
Hey Ruth, would you like to do some bank shifts next week?
Oh no, so I can't agree with that. Next week.
Just 2 shifts. Now? Just 2 shifts, that's all. I'm not asking you.
Do I have the lens?
Oh, I've not looked one out.
What?
I have looked one out.
Can I see the biometric, please?
What about the week off? No?
Excuse me?
Operation finished.
There we are.
Mr. Smith.
Thank
take
you.
this off.
Did you leave me short-sighted, doctor? As you have told me before the surgery, I'll be able to read with this eye.
Now, it's important to stress that was a simulated scenario. But just think about the behaviours of that surgeon. Looking at that video clip, Would you want to go to see that surgeon for your cataract operation? And you're basing that decision solely on the non-technical skills of that surgeon. We're now going to show you a clip which shows good non-technical skills. And I want you to see the difference between the good clip and the bad clip.
Okay, Mr. Smith?
Yes.
So we're going to go ahead and do your cataract today, right? As we discussed in the clinic beforehand.
That's right, yes.
When I saw you on the clinic, you wanted me to make your right eye short-sighted.
Yes,
yeah?
I did, yes.
And you keep, obviously, you had your left cataract done sort of last year.
Yes,
and that was very good for the distance.
Yes.
So you used to wear contact lens. Okay, guys, quick surgical pause now. Everybody, we've got 4 on the list. Everybody knows everybody?
Yeah, but I'd like to introduce a new member of our staff here.
Okay.
It's Fiona.
Fiona, hi Fiona.
Hello.
Hi, I'm Michelle. You know George? George is one of our
Hi.
trainees.
Hello.
Okay. Have you got experience in eyes before?
A little bit.
Okay, a little bit. Okay, so you'll be watching us. You can ask us any question after the procedure finish. Okay?
Thank you.
Good, okay. Well, let's, for first patient, we've got John.
Can we do a pause before we start? Is that okay?
Yeah, okay, let's do a check.
Okay.
Okay, you can put your hand down, sir. Hi, Mr. Smith.
Just hold on to my hand there, Mr.
Good.
Smith.
You got
all right?
oxygen going through? And all going to be fresh air. Okay. Well,
You know, Jenny, I note with keen interest that you are actually on the road twice more than me for next week.
excuse me, Gary. I would rather if you finish that after this, the list. Is that all right?
Oh, I do apologize.
Okay,
I'm
no, it's
sorry.
fine. It's just so I got full attention of
Sorry,
the nurse.
doctor.
That's all right. It's okay. Right, let's do Rex's now. Okay, that's great. Okay, George, that operation finished. Okay, Mr. Smith, I'll just take the drape off. Thank you.
All finished?
All went very well. Well done. You
Thank
did very well.
Did you leave this eye short-sighted?
Yes, exactly as we talked in the clinic before,
Thank you.
outside.
Thank you.
All right.
Thank you.
Okay, well done.
Okay, so you now know what the non-technical skills are from the NOTSS taxonomy. You've had examples of how they can be used. Let's go back to what we talked about in the first lecture and look at the surgical checklist. So why does the surgical checklist work so well, if it's used properly, when there's no change in technical ability? Here's the checklist. And we're going to focus on the time out, the surgical pause, when every member of the surgical team is in the operating theatre before the operation starts. So let's look at the time out. What is it that can be brought together that we've talked about today in the non-technical skills? Well, for start off, we introduce ourselves. We make sure that everybody in theatre knows who everybody is by name. There's very good evidence that if people speak at the beginning of the operation, if people talk to each other, then they're going to be more likely to put their hand up during an operation and say, I'm uncomfortable, or to point out when something may be going wrong. So teamwork is enhanced simply by taking part in the surgical pause. We discuss the procedure that's going to be undertaken. We discuss a little bit about the history behind the patient, about what may or may not be required in the operation. And we share that with other members of the operating team so that everybody's situation awareness is shared, and we have what we call a shared mental model. We discuss what might go wrong and what we might need if it goes wrong, so that other equipment may be available. And finally, leadership and decision-making. A good leader takes part in the surgical checklist, the surgical pause, supports others, encourages them to speak. And doing the surgical checklist is an example of setting and maintaining standards. Making sure that protocols are followed, perioperative antibiotics are given, DVT prophylaxis, setting and maintaining standards, supporting all the others, and of course the decision-making that's required to do that. So the surgical checklist really brings together all these non-technical skills that we think are so important. And that's why the surgical checklist works so well.
And the surgical checklist is a vital way that you can enhance both you and your team's non-technical skills. But it's not the only way. One of the most important ways that you can set the tone for the day is your pre-op briefing. This is when you set the tone for how you want your team to behave. But it's also how you increase their situation awareness and start to get the shared mental model that's so important to good non-technical skills. And your briefing should focus not only on the surgical task at hand, but also on how you are going to work as a team for that day or for that operating theatre list. And we know what effective briefings are. Encourage participation by all your team members. As Simon says, once your team members have spoken up, even by introducing themselves, they're much more likely to speak up if they see something wrong or something that's about to go wrong. Your team should feel that they own the surgical briefing. This is where you start to build your team in the morning. And it should be organised, and it should predict what is going to happen throughout the day. In addition, you should use this to improve your team's decision making. You can do this by discussing contingency plans. What might go wrong during a particular case? How will the team know if it's gone wrong? And what do you want the team to do if that does go wrong? That means if the adverse event does happen, when everyone's stressed, when your working memory is under pressure from stress, that means that your team already has good decision-making skills because you've already discussed these things in advance. Now, it's a common excuse that we do not have time to do things such as briefings. Unfortunately, that excuse we know is not true. If you look at this data here, we're looking at total hip joint replacements. As you can see, when briefings and debriefings were introduced, actually, both time taken to perform the procedures and patient turnaround time decreased because the teams were more able to cope with what was happening ahead. More efficient use of time was made because they discussed all these things prior to the cases. In addition to a briefing, a debriefing is vital. And that can be difficult. It's done at the end of the list, often at the end of the day. Everyone's tired and wants to go home. But it is really important for a high-functioning team that you debrief. That was one of the 5 elements of high-performing teams that Eduardo Salas described that Simon demonstrated on a slide in the teamwork section. And it's very important that this debrief focuses not only on the practical aspects of the surgical task, such as how well the operation went, but you should also focus your debrief on how well you worked as a team.
Thank you, Craig. Thank you for listening. We hope that we've gone through and explained the non-technical skills that are important to support surgeons in the operating theatre, both with their individual skills and to allow them to get on better with a surgical team. The NOTSS project was run by Professor Rona Flynn from Aberdeen University, and carried out by Dr. Stephen Newell, who's a postgraduate psychologist currently working in Boston. And we're grateful to them for all the work that they have done over the last 12 years or so in setting up and developing the NOTSS taxonomy. You can see from this slide where NOTSS is now being used around the world. It's been translated into Japanese, it's been translated into Danish, and there are currently other projects in other countries to translate it and introduce it into their own surgical system. It's being introduced broadly in America, as you can see from this slide. And in the United Kingdom, the NOTSS work-based assessment is now going to be part of all surgical trainees' assessment. So thank you for listening. We run NOTSS master classes at the College of Surgeons in Edinburgh and around the UK and abroad. It's a one-day course, both for consultant trainers who are interested in understanding more about being able to assess, observe, teach non-technical skills for surgeons. On the Royal College of Surgeons of Edinburgh website, there is what's called a NOTSS in a Box, which is a short video explaining how to use the taxonomy to observe an operation. And there's also 6 electronic modules produced by Professor George Youngson from Aberdeen University for NOTSS for trainees. If you go on the website, all these are available to you. The NOTSS taxonomy is freely available through the college website and also the ISCP website given here. And further information on the other taxonomies we mentioned earlier for anaesthetists and scrub practitioners can be seen on the Aberdeen University website. So thank you for listening to both of those 2 lectures, and both Craig and I hope that they have been useful to you. Thank you.